Stridor. Q. Write a short note on stridor and its management. Stridor is a high-pitched sound, caused due to an obstruction in the airway. It can be inspiratory, expiratory, and biphasic. Types. Stridor. Inspiratory. Produced in lesions of supraglottis or pharynx. Examples, laryngomalacia. Biphasic. Produced in lesions of trachea and bronchi. Examples, expiratory. Produced in lesions of glottis and bronchial foreign body tracheal stenosis. Subglottis. Examples, causes, congenital. Vocal cord palsy, subglottic stenosis, laryngeal papilloma, laryngeal web. Laryngomalacia, laryngocele, laryngeal cyst. Causes of stridor 7. Acquired neoplastic. Laryngeal cleft. Laryngeal web. Congenital vocal cord paralysis, congenital subglottic stenosis, subglottic hemangioma. Laryngeal carcinoma, thyroid cancer, metastatic lymph node hemangioma. Juvenile recurrent respiratory papillomatosis, infectious inflammatory. Epiglottitis. Croup, laryngotracheobronchitis. Traumatic. Post-thyroidectomy, post-laryngectomy. Prolonged intubation. Miscellaneous, neurogenic paralysis due to acquired lesions. Laryngitis, retropharyngeal abscess, diphtheria. Tetanus. Tuberculosis. Cystic hygroma. Goiter. Laryngeal edema. Laryngotracheal trauma, foreign bodies, latrogenic. Traumatic intubation. Idiopathic. Management. Stridor is the presentation of an underlying disease and is a symptom. The treatment depends on the cause. The importance of good history and examination cannot be stressed. History. A detailed history should be elicited with the patient's demographic details. Congenital lesions usually present with stridor in the first year of some foreign body ingestion, it should be noted. Examination. A comprehensive examination of the ear, nose, and throat should be done. A general examination should be done. Any signs of flaring of alinosi, suprasternal and substernal retractions must be noted. The onset, duration and progression and relieving and aggravating factors should be noted, as laryngomalacia worsens on feeding and relieves when the baby is put in the prone position. Any history of recent surgery or recent admission history should be duly noted. Patients presenting with infective lesions should be asked for fever. If there are any associated findings such as fever, dysphagia, and otinophagia, it should be noted. If there is a history of a detailed ear, nose, and throat examination should be done. The neck should be examined for any thyroid swelling, neck node, and the presence of laryngeal crepitus. Flexible nasophryngolaryngoscopy or a rigid endoscopy or indirect laryngoscopy should be done to look for any lesions of the supraglottis, subglottis, and glottis. Vocal cord movement and symmetry should be duly noted. Investigations. Complete hemogram should be done to look for raised white blood cell, WBC, counts in patients of epiglottitis, croup, diphtheria, etc. Arterial blood gas analysis may show a washout of carbon dioxide. And respiratory alkalosis. Swab for Albert stain should be sent for diphtheria. Radiopaque foreign bodies can be seen on chest x-rays. However, radiolucent will be seen as either hyperinflation or collapse of the lung depending on the site of obstruction. If there is a large goiter, there can be a shift of trachea noted on the x-ray. CT scan 1 He neck can be done for abscess, laryngeal cancer, thyroid swelling, metastatic lymph node, and mediastinal lymph node to ascertain cause of stridor. Treatment. The patient's oxygen saturation (SPO) should be monitored. And all efforts must be made to prevent respiratory fatigue %. Patient should be put on high-flow oxygen, the cause of the stridor should be ascertained, and management must be tailor-made. If the patient's distress worsens, intubation should be considered. And if for any reason it is not possible, the patient can undergo a tracheostomy to secure the airway. The treatment will be cause-specific.